Hello everyone. Welcome to the Difference, Gender, and Sex Make to the Work Disability Outcomes webinar with Dr. Mika Cohern. This webinar is part of our Return to Work, Stay at Work series, and we're glad to have you with us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is made possible through the support of the Community Grants Program with the BC Government, as well as through donations and memberships to our organization. As mentioned, my name is Tanya, and I'll be moderating the session and handling the Q&A today. And our speaker is Dr. Mika Cohern. Dr. Cohern is a professor and head of the Occupational and Environmental Health Division in the School of Population and Public Health at the University of British Columbia. She holds a PhD in Occupational Epidemiology and a Canadian Institutes for Health Research Chair in Gender, Work, and Health. Her program of research focuses on the epidemiology of work-related injuries, disease, and disability, as well as the evaluation of workers' compensation programs and policies. And I will hand it over to Dr. Cohern.
Thanks so much, Tanya. So good morning or good afternoon, depending on where you are listening from today. I want to thank you very much for this opportunity and invitation to present to you today, and also just want to thank the Institute for Gender and Health, who sponsor the chair program in Gender, Work, and Health, and really is responsible for stimulating research in this area and sponsoring or supporting my research. My overall intent today is to spark some discussion and debate on gender and sex differences in health with a focus on work-related injuries and disability. I'm going to pull in some other examples that are not necessarily specific to work-related injuries and disabilities, but pulling in those examples where I think they have some relevance to prevention or treatment of work-related conditions. The talk's kind of organized into 4 components. I want to provide a little bit of background for everybody as to why I think this matters. And then I'm going to move to some examples from my research about gender-sex differences in workers' compensation outcomes or work disability. The third component is just pulling in some examples from other people's research that I think is very interesting. And I'm going to conclude with some resources that may be of interest to people. So moving to the first component of the talk in terms of just some background information, and what do I mean when I say gender and sex? For the most part, when I say the word sex, I'm referring to the biological construct, the thing that encompasses differences in hormones and genes and anatomy and physiology. And typically sex is something that affects the prevalence or occurrence of disease and health conditions as well as their course and treatment. And it affects differences in things like drug absorption and body composition and metabolism. So really more of the kind of physical biological constructs. When I talk about gender, it is more the social construct or social definition. It's the things we think about when we talk about our roles, our identity, our relations or relationships. It's often linked to things like power and to our economic and social status. It can be culturally specific and temporal, meaning the definition of gender and how we identify changes over time. And typically in terms of health, gender is something that affects our interactions with the health system, with providers, as well as with our working environments and with employers. So those are the 2 kind of basic definitions in terms of gender and sex. More also in terms of the background, setting the stage for this talk and why it matters. I think most of us would accept that males and females are different, that men and women are different. And I think that most of us would agree that these are not necessarily binary concepts, just male, just female, but rather exist on a continuum. We talk about maleness or femaleness, or we talk about masculinity and femininity, and we even talk about differences from XO to XX to XXX to XXY to XYY to XY chromosomes. Or we can also think about it, as my colleagues have started to point out to me, less of a continuum and perhaps more of a mosaic of differences that define male, female, men, and women. Much of our understanding of disease processes and treatments begin with preclinical studies that use non-human animals and cell cultures. Such studies are integral to biomedical research and to the development of drugs, devices, and treatments, all of relevance to work-related injuries or to injuries in general and disability. Most preclinical or biomedical research, however, has been conducted with inadequate consideration of sex and has typically been conducted or based on male rodents or rats. So why all the fuss? Sex represents one of the most evolutionarily well-conserved differences in biology. Yet it is one of the most underappreciated differences in biomedical research. Although many factors can influence an outcome, sex is fundamental and affects the whole of the population. As such, it can be used to disaggregate data and explain heterogeneous disease outcomes and responses to treatment. To remedy this situation, the Canadian Institutes of Health Research, which is part of the Government of Canada's health portfolio and is Canada's largest federal health medical research funder, in 2010 implemented a sex and gender analysis policy that requires applicants to declare whether sex or gender will be considered in their research or why it is not relevant to their research proposals. And this has been mirrored by many research funders and institutes in Europe as well as across the border, including the National Institutes of Health Research in the US, which requires applicants to report their plans for the balance of male and female, both subjects, cells, animals, in studies in all of their applications, unless this inclusion is unwarranted. A recent analysis of CIHR research grants reviewed since enacting the policy reveals variable inclusion of sex or gender consideration in health research. Clinical and population-based projects are more likely to report analyses of sex or gender differences than are the basic biomedical sciences. In this latter group, which includes molecular biology, neuroscience, genetics, immunology, 80% of the applications indicated that biological sex was not a consideration in their studies or not warranted. So this data implies that many members of the health research community devoted to the discovery of biological mechanisms, including important information in terms of how it relates to drugs and to treatments and the reactions and recovery response to many of our medical treatments or modalities, do not consider sex an important variable. And just by way of conclusion here on this background information, I want to be clear that this policy was not intended to convert researchers or even practitioners to the study of sex effects, but rather to promote the design of research studies capable of discovering sex effects in their studies where they exist. So having said all of that, much of the preclinical and biomedical research has been based on male rats. Despite that, this has not necessarily translated to better health outcomes for men or for males. And I just want to, as part of the background here, provide some indications of the differences in health outcomes for males and females. Often when I give this talk, it's this perception that females are underrepresented or women are underrepresented in research and therefore disadvantaged, but in fact many health outcomes would indicate that males or men have poorer health than females, and I cite a few examples for you here in terms of disease outcomes, health behaviors, and interactions with healthcare system. So now I'm going to move to a few examples from my research that have prompted, I think, interesting questions driving discovery in terms of gender-sex differences as it relates to injuries and to disability. I am, however, going to start with a study that is not my own, and I present it here because it really spurred me to think about this issue in my research, where I hadn't necessarily given it a lot of consideration before, other than just adjusting for whether it was a male or female in my studies, but not really looking at differences. This was a study done in Ontario by Burkhoff and colleagues, and so a very influential study for me, where they asked physicians to perform an assessment of 2 standardized patients with moderate knee osteoarthritis who differed only by their sex, one man, one woman. In this case, the knee arthroplasty is the definitive treatment for relieving pain and restoring function in people with moderate to severe osteoarthritis for whom other medical therapy has failed. And physicians were informed that they were participating in a study about clinical decision making, but were not told that the purpose of the study was to assess the effect of patient sex on decision making. The standardized patients memorized identical scenarios that included functional capacity, pain severity, sleep disturbances, the use of pain medications, and all other treatment modalities. Their socioeconomic status was scripted as middle class. They both had physically undemanding part-time jobs. Chronic knee pain was given as their chief complaint so that the physician encounter would be focused exclusively on the osteoarthritis. Their scenarios were scripted such that usual non-operative treatment options had been exhausted. And to ensure standardization of the scenario, each standardized patient visited the physician only once and were given more than 24 hours of training in terms of the presentation of their clinical symptoms. So to the best of the researchers' abilities, the only thing that differed was that one was male and one was female. And after presenting and asking physicians to make a clinical decision on these patients, the odds of an orthopedic surgeon recommending total knee arthroplasty to the male patient was 22 times more likely than for the female patient. And the odds of a family physician recommending total knee arthroplasty to the male was just twice, but still twice as often than a female. And I'm sure many of you might ask whether they looked at the gender of the surgeon or the physician. They were unable to do that for the surgeons because they were all males, but they were able to look at that for the female physicians, and it didn't matter whether the physician was male or female in terms of this decision-making process. So for me, a fascinating study that made me pause and think about what was going on here in terms of at least treatment for musculoskeletal injuries or musculoskeletal conditions. I'm now going to move to some of the work that I've been doing because it prompted me to think about this in the data that I'm using and looking at in terms of workers' compensation outcomes. And I highlight for you here a look at work disability duration. So the number of days off work, or in this case with the data I have, the number of days on a workers' compensation claim. So these are all for work-related injuries. And I looked at multiple different musculoskeletal injuries, back pain, musculoskeletal conditions like repetitive strain injury or tendinitis, and in this case here highlighting fractures. And I highlight this one because I think it's interesting. I think I would have thought there was less variability in the clinical treatment and recovery pathway for fractures than for the other conditions. And what you see here at different points of the disability duration, so the 25th, 50th, and 75th percentile, meaning injuries or claims that have kind of a short disability duration, those that have a typical disability duration, and those that we would describe as long disability duration. At all those different points, women having a longer disability duration than men in terms of being on a workers' compensation claim. And this didn't seem to matter in terms of their occupational groups. When you look at individuals in healthcare occupations, in this case looking at registered nurses or care aides, or looking at people in the primary resource sector such as forestry workers, in logging, forestry, chainsaw, skidder operators, all those good BC occupations, women taking longer to return to work than men at all points of the distribution, in this case highlighting fractures. But I could show you 100 different of these slides for different types of musculoskeletal injuries within different occupational groups, and the story was the same. The next slide I'm highlighting for you here is to show you that this gender difference in terms of women taking longer to return to work than men, persisting in different workers' compensation jurisdictions. Here are 3, BC, Manitoba, and Ontario. And these data points are looking at the ratio of women coming off of claim compared to men. So the data points here are relative to BC men, and so it's showing in each jurisdiction that women are less likely to come off of claim, in other words, have longer disability duration than their male counterparts in this jurisdiction. Even though, which is a separate conversation, there are great differences in disability duration across jurisdictions. The point of this slide is that women are taking longer to return to work than men in jurisdictions in Canada. So it's a good question of what does this represent? Why this difference exists and persists for injury type and for within occupation and within jurisdictions? Is this biology? Is this physiology? Is this social roles? Is this interactions with employers, with healthcare systems, with the insurance system? Is it different treatment regimes or response to treatment? Is it different recovery patterns, physiology? Is it all of this? It's interesting, going back to the fracture example, people who do research on bone density indicate that this is influenced both by sex biological factors such as sex hormones as well as gendered social characteristics, including stress, pardon me, occupation, physical activity. So it could be a combination of things that are explaining this very persistent difference in work disability duration. So it prompted us to think about, could we tease out why this is occurring, at least in the BC context? And one of the things that persistently comes up when I present this disability difference, people say that it could be a socioeconomic factor and or having young children and women still perhaps taking on a larger role in terms of family responsibilities in the home environment outside of work and having different opportunities for recovery from injury. So we tried to look at that in the data that we have on BC workers and with a workers' compensation claim. So these next 3 slides showing you disability duration again at the 25th, the 50th and 75th percentile, shorter disability duration claims, longer and regular or medium disability duration claims for males and females. First line, just generally overall their disability duration here for back strains, and then looking at the combination of the effect of having a low income subsidy, so some kind of an indication of a lower socioeconomic status, and the combination of having young children in the home or at the same address where you live. And these 3 series of slides show you that women still have a longer disability duration than men, that having a combination of a low socioeconomic status as indicated by a subsidy payment and having dependents under the age of 18 in your home increases your disability duration. But across these three slides, for back strain, for fractures and dislocations, and for repetitive strain injuries, the impact of low income and dependence was greater for men than for women in terms of lengthening the disability duration. So it didn't seem to provide an explanation for us in terms of explaining the overall difference in disability duration for males and females in this workers' compensation data set. So I'm going to flip between those slides. So women still having longer disability duration than men, and those with low income and dependence having a longer disability duration still, but the impact of that for men from the overall median days was greater than for women, for females. So then we said, okay, if it's not socioeconomic or your kind of social environment, family situation, gender roles, perhaps it's something to do with your interaction with your employer and in the compensation system. So we looked at the offer of modified return to work as a potential difference in terms of disability duration. And we're just starting to look at this, again, across these three types of musculoskeletal injuries by males and females. And what you see here, with one exception that we could find stratified by occupational group, that women are offered modified return to work more often than men and participate in modified return to work more often than men. And that persisted for the same injury within the same occupational group, with one exception where there's a very small difference with males and females for fractures in healthcare occupations. So it's intriguing to think about how that might be impacting the longer disability duration, and whether that provides any kind of an explanation. We would have thought that modified work would have helped return individuals to work, and as part of recovery, generally perceived as a positive thing to try and return to some kind of duties at work and facilitate recovery and return to work. So here again, not seeming to offer an explanation for the disability duration. This is illustrative only. We're starting now to look at differences in work disability policies, and just highlight this for you as an illustration where we're comparing the province of British Columbia with the state of Victoria in Australia in terms of some policy differences and whether that helps explain some of the gender differences. This is an intriguing example where the state of Victoria has had a salary cap on the maximum amount of benefits that you can earn as an absolute value for a very long period of time, and then shifted that cap, allowing individuals to earn slightly more. Whereas in British Columbia, we have had a percentage increase in the maximum amount of salary that you can receive on workers' compensation benefits. And what happened in the state of Victoria, when they increased the maximum amount as a total amount, starting to shift the disability curve, longer disability durations for men with no impact on women. So those who earn the highest income were able, with the shift in the cap, to earn closer to their salary and perhaps being able to stay on benefits longer as a result, and that differentially impacted men compared to women as an illustration of a policy difference that had a gendered effect. I'm now going to shift, pardon me for a moment, I'm now going to shift to some other examples that I think are intriguing. This is not my research, but the research of others that I think has some relevance in terms of treatment for work disability or for musculoskeletal injuries broadly. So this is work that was looking at pain responses. So women tend to be diagnosed with chronic pain more frequently than men. and seem to respond differently to some pain medications. The generally accepted notion in pain research, as I understand it, has been that immune cells called microglia are responsible for transmitting pain through the nervous system. However, this theory is based on experiments carried out overwhelmingly on male rodents. In a new study published in Nature Neuroscience, researchers at McGill's Pain Genetics Lab interfered with microglia functioning in terms of trying to understand pain, transmission of pain, and found that while pain was blocked in male mice, it had no effect on pain transmission in female mice. And they discovered an entirely different type of immune cell, the T cell, appears to carry out this function in females. And as a researcher, I'm just going to make a side note here because often when I present this research, at least to a research crowd, one of the arguments for not including female rodents or rats in research having to do with the female reproductive cycle and how that complicates research both in terms of the expense and the ability to tease out the effect of the experiment. But in 2014, a group of researchers from the University of Chicago and Berkeley published an analysis of over 300 articles that measured nearly 10,000 traits in male and female mice or rats. The analysis showed not only that female mice are no more variable than males, but that males are actually considerably more variable on several traits. And given these findings, the authors suggest that experiments don't necessarily need to monitor the female reproductive cycle or estrous cycle. This is good news given that the process for doing so is time-consuming and results had claimed to be results and barriers to conducting research. If and when evidence shows that reproductive hormones affect specific traits or treatments in humans or animal models, researchers should incorporate female reproductive phases in the study design. But otherwise, their study would suggest there's no justification for the exclusion of females or female rats from studies. I'm going to now share some research with you from researchers out of Montreal who are doing specific lab-based research on muscle fibers as it relates to musculoskeletal injuries and work-related musculoskeletal disorders. There's a general consensus, at least in high-income countries, that musculoskeletal disorders, and particular work-related musculoskeletal disorders such as back strains or repetitive strain injuries, affect women more than men. The most recognized hypothesis, at least put forward for neck and shoulder repetitive strain types of musculoskeletal disorders, is what's called a Cinderella hypothesis. It's based on Cinderella fibers, which are type 1 muscle fibers, slow, fatigue-resistant type of muscle fibers, connected to what are called low recruitment muscle units. That is, the muscle units that are the first ones to be recruited and remain activated for a long period of time during what are sustained low-force efforts. So what we might describe as the types of tasks that are repetitive in work tasks, job functions. Muscle injury results from overload, accumulation of calcium ions, preventing muscle relaxation, and structural damage to these fibers, implying insufficient regenerative processes at the injury site. Studies have shown a reduced ability to modify muscle activity of patterns in women, notably women with sustained, continued use of the same regions, in this case of the trapezoid muscles, the upper neck, shoulder muscles, even in the presence of pain, whereas men respond differently by using different muscle fibers. So Julie Cote's lab in Montreal, this lab-based studies with not rats, but in this case actual males and females doing upper arm repetitive tasks, looked at these muscle fibers in the lab. And the general conclusion is that men find more ways to change their pattern They are more flexible, variable, and adaptable in the use of their muscles for repetitive tasks. So when you look at kind of motor variability or a measure of repeatability, women show less variability in the use of muscle fibers. So they're better repeaters. They use the same muscle fibers over and over again than replacers, which is what men do. They replace their muscle fibers or have more muscle variability when doing a repetitive task. Also differences in functional connectivity. So that's how closely a pair of muscles are in tune with each other. So this connectivity is much higher in females. Their muscle fibers communicate more, and that is believed to spread fatigue more quickly because the muscle fibers are more communicative or connected. And so again, just to summarize, based on these lab-based research, the male muscle system is more flexible, variable, and adaptable in response to repetitive activities. Even in this case, in the presence of pain for women, they tend to use the same muscle fibers. I'm now going to pull from an even wider body of researchers. This is research done here in my school with colleagues looking at cardiovascular research. And the reason I pull that in is because highlighting, in this case, differences in interactions with the healthcare system that may have relevance, broader relevance for the treatment of things like pain and disability. So I guess try to pull from parallel research to illustrate gender differences in interactions with the healthcare system. So here, Kate Somalina and others, Karen Humphreys from St. Paul's Hospital, doing a lot of research on gender differences in cardiovascular outcomes. In this case, acute myocardial infarction admissions to BC hospitals. So this was a population-based cohort study using our administrative health records in British Columbia from 2004 to 2011. Included all healthcare interactions, prescription drugs, a wide variety of socio-demographic characteristics and mortality treatment information. And included individuals who had survived for at least 1 year following their hospital discharge for a heart attack. And patients were evaluated for whether they initiated and subsequently filled prescriptions or adhered to prescriptions such as beta blockers and statins for treatments of their conditions. So the majority of people did initiate treatment, appropriate treatment, given their contraindications within 2 months of discharge, but they also discontinued treatment or do not refill their prescriptions over time. But there was a gender difference. What they call younger women, given the outcome here is a heart attack. So younger women under the age of 55 years were significantly less likely to be on optimal pharmaceutical therapy. And this difference disparity was driven in treatment initiation and not treatment adherence. So there was a difference in terms of the either the recommendation or the initiation of those treatments, particularly for younger women, that was not related to adherence. The final example that I want to pull from, because I think it has relevance when we talk about pain, disability, and work-related conditions, is that associated with mental health, and in particular depression. Again, this is pulling research from UBC colleagues. John Olaf here in the School of Nursing has done a lot of research on men health, and in particular men's mental health and depression. And men are diagnosed with depression much less than women, half the rate typically in some of his research. He takes the stance that this long-standing epidemiological profile of men being diagnosed less or having less depression than women typically projects it as a women's disease or illness or condition. And it contributes to men's resistance in seeking professional help for depression. and then challenges our ability to deal with that as a comorbid condition that contributes significantly to work disability, to treatment adherence, to recovery, return to work. And so I raise that here as another interesting gender difference and challenge that we face in terms of dealing with pain and disability and recovery. So I end there in terms of drawing upon some interesting examples solely for the purpose of illustrating where this might matter, why it matters, interesting examples of where there are gender differences in health outcomes, and potential differences in treatment and interactions with our healthcare systems or with the insurance provider. And to, I guess, stimulate discussion and debate of how that might matter in terms of people's practices or interactions with disability and recovery. And I just thank all of the groups and individuals that have made some of this research and my time possible. And I'm going to end with some resources that may be of interest to you. The Institute for Gender and Health, which is one of the institutes nested within our National Health Funder, the Canadian Institutes for Health Research, has free online modules for individuals who might be interested in learning more about including gender and sex in their practice and in their research. They're free to you, and you can get a certificate of completion for participating in them to spur you to take a look at those online resources. And there are also some interesting reading material. A primer on gender and sex differences in health research, and case book to illustrate different examples of where this might matter across different types of health examples. So those are available to you for additional reading. My email address is part of the opening slide, so you are welcome to contact me if you want additional resources after the discussion today. So I conclude my talk there, and we'll open it up for discussion, which I believe Tanya is going to moderate for us. Thank you.
Yes, thank you very much, Mika. That was a really great presentation, and quite a few studies that I had not seen recently, especially around the chronic pain. So that's really great. Let's see. So we had a question around the differences that you've discussed with these particular research articles. Would you? There was a little questioning around is this related more to sex or to gender or both?
I think that is a very good question, and I think in some of those examples one could absolutely say that it is sex. It is more of the biology or physiology. For example, the work by Julie Cote would seem to suggest to us that that is a basic biological difference in the way that we use our muscles that I think would be harder to explain in terms of our gendered roles. Whereas when you look at the example in Ontario with the interaction with orthopedic surgeons, for me that appears to be more of a gender difference in the perceptions perhaps of the clinician, and given a standardized presentation of sociodemographic, occupational, clinical, and treatment characteristics, that males are more likely to be recommended for surgery than females as the next course of treatment, for me seems to speak to gendered roles and gendered perceptions of what is the next course of action. So those for me are clear examples of a gender difference versus a sex difference. When you start to look at something like the slide I presented on disability duration differences, I've got to think that that's a much more complicated story, where physiology or sex might explain differences in the nature of the injury and the recovery of the injury, such as fractures, where we know there are differences in bone density, And then on top of that, differences in interactions with the insurer or the healthcare provider in terms of treatments, the ability to return to work in a modified capacity and how that might affect disability duration. So that's a much more complicated story and is very challenging to tease out the gender differences. And I believe when you start to look at things like a gendered role like children in the home, and then you start to look at treatment differences, it's probably a bit of a combination of the two of those. So it depends on the outcome you're looking at and the ability to measure some of the gender sex constructs. Some stories are cleaner and some stories are much more of, as I said earlier, a mosaic of influences.
Interesting. Yeah, that was what I was thinking as you were giving the presentation as well, is that some seem clearly to be more around the physiology and some more around the societal perceptions of what that means and what each gender, how they should be treated or how to interact with them. So, yeah.
Yeah.
Let's see. There was another person who was asking, you had the slide that said that every cell is sexed, and they were wondering how that, as well as some of the items you discussed, might present for people who are gender neutral or transgender.
Mm-hmm. Yeah, and I think that goes to an opening point where even though a cell has sex characteristics and we have different kind of gendered roles in society, that in fact this is, if you prefer the term continuum, or as some people are advocating for these days, much more of a mosaic. And I think that exists both at the cell level and in the broader societal level, that there is a continuum of sex characteristics in terms of the, for example, ranging from everything from XO to XXX to XXY or XYY, kind of combinations of our cells. It is not a binary construct even at the cellular level. There is a continuum or a mosaic, and that translates also, it is not an either or in terms of male or female in terms of our gender roles. There are lots of very interesting, great research on what we call masculinity or femininity. That is a huge range or continuum or mosaic of characteristics. And even within that, we might describe ourselves as having a bit of both, and in some cases saying I'm much more masculine on this characteristic or I'm more feminine on this characteristic. So much more of a mosaic. So I think even at the cellular level, there is a continuum or a mosaic of characteristics that define sex.
Wonderful. And then have you found in these kinds of research that are addressing issues around sex and gender that the discussion around transgender and mosaic like that is part of the research, or do you find that that's not the case? Or
yes, so there I'm encouraged. I think we have a long way to go, but I am encouraged that, for example, our federal government is starting to think about this issue with our national surveys. For example, with the census survey that some of you may have recently received, asking binary questions, but in fact their response to that, when you complain, which I did, when you complain about that, is that they felt it important to get the census out, but they are seriously considering for the next census questions that enable people to describe their sex and gender in a much more fulsome way. And that's also true, I think, going to start to happen with some of our Statistics Canada surveys, our health surveys, enabling individuals to describe. One of the ways I've heard it handled is asking individuals to describe at birth, would you say that you were born male, female, and now as an adult responding to this survey, how would you describe your gender, allowing people opportunities to try and differentiate or provide helpful information for understanding biological and gendered differences. So there is encouraging discussion or dialogue even for our national health surveys. And I know that there are colleagues here working in health services research who are strong advocates for providing evidence and information to clinicians for decision making, for taking patient histories, and then using that information to help with treatment options, recognizing treatment interactions with the healthcare system. I haven't, to be honest, heard as much of a discussion with other kinds of, say for example, like the workers' compensation system in terms of their data collection. Being able to capture some of that where it might matter for treatment or for recovery. But I think I'm encouraged that the dialogue has started, and organizations who collect data and organizations who might use that data for example treatment like physicians are starting that conversation.
Very good. Let's see, we don't have any other questions from participants at the moment. If anybody has any further questions, please feel free to type it in now. I did have a question. I was curious, you mentioned both that like some of the examples you gave showed that there was more of a disparity on the side of females and women getting certain kinds of treatment, and really only the one on depression for it being an issue with men. Do you find that, like, is there more disparity on one side or the other, or is it just a lack of information and research for both sides? Or
I think I guess part of my hope in presenting one of the earlier slides is to try to portray a bit of a balanced picture. So one of the earlier slides that I presented saying that for the most part men actually have probably worse health indicators than women overall at a population health level. They die earlier, they die younger, they have more chronic conditions, those kinds of things. So I think at a population health level, one might argue that men have worse health overall than women. And then when you start to bear down on some specific examples, you do see perhaps other examples where women might have longer disability durations, might have different interactions with the healthcare system that do not seem favorable. I think the important point is where you think it matters, at least from my researcher standpoint, is to think about it, think about where it might matter, and to investigate it in research. The flip side of that then from a practitioner standpoint is also to pause and think about, does this matter? Should it matter in my interactions with individuals, in the treatment options, asking questions about equity or where you think a bias might exist, and ultimately to provide the most effective treatment. It may mean to ensure you're offering the same treatments to patients before you, such as the knee surgery example, so that males or females are not disadvantaged or treated unequally, and in some cases offering different treatment regimes because males or females respond differently to drugs or to therapies. And I guess the main point is to ask the question or to pause to think about it.
Wonderful. Someone asking, you mentioned changes to disability income duration in reference to policy differences. Did the longer duration of disability income negatively or positively impact return to work success? And were there sex differences?
Yes. So it's a good question of whether you would define it as a negative outcome. So in the example from the state of Victoria in Australia, they had for a long time a set amount that one could receive for salary income replacement. So there was a cap, a set amount. And when they altered that cap, so they increased it, you could earn more, what happened is that the disability duration for men increased but did not change for women. Now, one could argue that and the explanation for that is that, rightly or wrongly so, men have the higher incomes in both jurisdictions here and in Victoria. And so when able to replace that income at a level that is closer to their actual salary while on injury or disability benefits, one could argue that that's a positive thing, that people are able to stay on benefits longer to recover and earn a similar income or as close as possible as allowed by the system, and that that's a good thing. The converse of that is that it differentially benefits men in terms of being able to stay on disability benefits longer. So it's a good question of whether that policy shift, the change in the cap, could be described as a positive or a negative thing. But the findings were that there was a shift in the disability curve, and that shift, longer disability durations, happened for men with the highest income.
Interesting. All right. And then someone wondering if there's a group or resource that you can suggest in terms of health services research, like around the workers' compensation system data collection and being able to capture some of that where it would matter for clinicians.
Not sure I'm totally understanding the question. So if a clinician is collecting data from their patient, maybe just a clarification.
Okay, I will wait for clarification from them. While we wait for that, there was someone who brought up Karen Messing's work on gender differences in occupational health,
yes.
and finding that that was very, very good, especially during these early days of this discussion.
Yes, Karen Messing from Montreal is a long-standing researcher in this field for more than 20, probably even longer, as long as I can remember, has been doing research on gender differences and occupational health outcomes. She wrote a pivotal book called One-Eyed Science, and she has updated that over time with various different publications, but a long-standing advocate for looking at differences for men and women in occupational health outcomes, in particular around musculoskeletal injuries and why women might have a higher risk or rate of musculoskeletal injuries as a result of the working environment and the design of equipment and equipment that's designed for men as opposed to women. Those kinds of things. So a very thought-provoking piece of work. So I would recommend One-Eyed Science as a great book to read, and then searching on her name you will find lots of additional resources from an occupational health and safety standpoint.
Wonderful. And then the person did give some clarification. She was, as far as you mentioned earlier, that you were excited about the dialogue that's begun between the collection of data from, for example, WCB and how that influences clinicians and health. And I think they're wondering if you have any suggestions of groups or resources around either how to get a hold of that data or how to maybe help influence how that's happening.
Right. So Um, One of the, I guess, in terms of influence, certainly because I work with the workers' compensation data, I have an avenue to advocate to them to improve the collection of, if, I guess for lack of a better variable name, sex in their data. To ensure that that's collected and is recorded, because that can be an important variable, as you've seen from the research, to at least look at differences at even just that level. So as a researcher, I have an avenue to say I work with this data and advocate for improved collection of that variable in their data. Separate from that, I mean, most agencies that collect data, whether it's the Ministry of Health or the Workers' Compensation Board, do collect sex, or asking people if they are male or female as a standard variable in the data. It isn't always necessarily complete, which is what we discover sometimes in the workers' compensation data, because technically gender doesn't matter to the provision of workers' compensation. So it's not the most complete variable, and we are advocating for improved completion of that in the data. Separate from that, one could start to move forward with a discussion about more nuanced variables in terms of male or femaleness, in terms of how people identify, and that's maybe the next step that one could start to look at. When dealing with patients, there are a number of scales or instruments. If, for example, you thought it was helpful to try and get some kind of indication of masculinity or femininity, there are helpful tools to collect that kind of data. And again, I think that has to be collected with purpose, where you think that it matters in terms of the delivery of treatment or response to treatment or recovery. And if that's helpful information, then it makes sense to collect it. So I can, of course I just don't have them on the top of my head, but there are scales and I can share those for that kind of collection of data. It's interesting, I've been doing some work with Peter Smith from the Institute for Work and Health, where because we work a lot with what we call administrative data, so that is things like workers' compensation claims data collected for an administrative purpose, administration of benefits, not necessarily collected for research purposes, and trying to get at a measure of gender in that data. And that also includes some of our survey data sets. And it's interesting, one of the most gendered variables still in this day and age is the occupation that you choose to do. It is a very gendered variable, despite improvements in opportunity for education and entry into the workforce and the kind of work that we do, and having more choice in all of those, choice and access. What we actually end up doing still remains quite gendered. And so what somebody does for an occupation can be a good indicator, at least, of gender from a research perspective in the data. I hope that answers their question. I'm not sure if I was still understanding it totally correctly.
They said yes. Thank you.
Good.
Wonderful. Okay, we are just a little bit past ending time, so I'm going to go ahead and close down the questions. Thank you very much, Mika, for the presentation and for helping us start this interesting and challenging discussion around gender and sex in research.